Okay, yeah, it looks like we are live. Yeah,
Yeah.
I'm always having to adjust this thing. It's stubborn. It moves after I have said we are live. Anyway, good evening, everyone. My name is Songes Ozibi, and I'm joined by my friend and brother, Dr. Sang Khozan. So he's going to tell us about himself just now. He is in Salford, Manchester. He's a Manchester United fan, but he assures me that he is not the Harry Maguire of the medical profession. although someone during COVID once advised him to leave medical issues to to doctors. Someone said, no, 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 you need to leave these medical issues to doctors. I don't know who you are. Those were the days. Kunjani, Khatev?
I'm good. I'm good, Khadeb. How are you? And I
I'm
like the
good.
fact that sorry you raised that issue because it arose for the simple reason that my handler doesn't and my bio don't say anything to what I do. And that was quite deliberate on my part because on the timeline I was just there to have fun, de-stress, and just enjoy myself. That was all. It's only when we bore the brunt of the pandemic that I decided to come in because there was a lot of misinformation going about. So I thought it's high time that I do my part.
But do you remember? Do you remember that there were instances where there were all sorts of legends because you and I got involved with that campaign with a we got involved with that campaign with the Solidarity Fund because there were all sorts of things. And I remember we had a Lonwabo Goli on one of the Twitter spaces, and people were concerned that they were not going to be able to do bedroom things anymore. So they wanted to know if they can take the vaccines or not. But look, I mean, we agreed to have this conversation because the NHI bill was passed by Parliament last year, and sometimes I often feel like we are a country of gimmicks, you know. I mean, universal health care is very important. So Rise Mzansi believes that we should have a very good public health and other public facilities easily available to members of the public so that people can have a healthy and good quality life and live a long life, by the way. So one of the things we've done in our documents is to put very specific measures because we choose to target problems now. So for instance, to say that you want to deal with non-communicable diseases. Well, what does dealing with them mean? What does dealing with them mean? You need to say they are at this level now per 100,000 people,
Mm.
wanting to get it to like 5 per 100,000 people within 10 years or whatever the case may be. And I feel that we have this situation in South Africa where we talk about things, we use big language, and we give the impression that we are going to solve the problem when we're not really going to solve the problem. So that's why we're having this conversation. So I'm gonna greet some people that have greeted. So Chwai Damdledle is my friend and a friend of the family. Sorry, Chwai, to pick you out of a crowd and 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 and, and send a shout out. Makashule Ghana is there. Godfrey is there. Moses Kumalo is there. So I'm sure there are lots of other people because the numbers on the screen keep growing. So, Doc, let's just start with you. So, before you got to the UK, where were you, and what were you doing? And don't start at UKZN unless you feel it's important.
It is.
That may be a long story.
How did you know I was going to start there? Now, I'm going to start there, Song, as well, because you call it UKZN. I'll
Yeah.
call it Natal University
Yes.
because that is when I got there and we stayed at Alan Taylor Residence next to the Mobile Oil Refinery.
Which
So
means you voted in '94.
I voted in '94. I always lead with that so that people can understand. And Mobile Oil Refinery is very important in the history of Alan Taylor because I still have a question. I'm digressing now as to why there were no mention of it being attacked when the medical students were there. Robert McBride, I'll find an audience with him one day and we'll address that. But anyway,
I can arrange it, by the way. Mr. McBride and I
no,
are
I just
slightly
want to
acquainted.
know how that thing can go next door when they are medical, who are supposed to be brothers, by the way, in the struggle at the time. But anyway,
Yes.
so I qualified in '95
Yeah.
from Natal University and went to do my internship at Livingston Hospital in Port Elizabeth. You guys call it Gqeberha now.
Gqeberha these days.
Yes. And then I was a medical officer in pediatrics. And unfortunately, when I got into medicine, there were people like Andile Povunga, Skomo Pomela, Fundile Nyati, who during school holidays would go to their places, just house sit, I will end there. And there were GPs in Port Elizabeth. So I was drawn to that. And then I opened my
Dr.
practice.
Povungana was my GP, by the way.
So I opened my practice there. We're doing locums for them. And I started working in Motherwell, NU4B Motherwell. When the Motherwell complex was being built, that's when I bought my practice there. So by the time it was up and running, I also opened. So I was just opposite the Motherwell shopping complex.
So the time that we were there was also the time that we had the famous does HIV cause AIDS?
Now, let me tell you. So I'm sitting in my practice. This lady comes in. Doc, I've got a problem. I've accepted the fact that my wife plays away. Sorry, my husband plays away games. I'm going to clean it up a little bit. I've accepted that.
Yeah.
Can I bring him in so that you can talk him about shin pads and protection when he plays away, so that he doesn't get injured or bring injuries to me at home?
Yes.
So the fellow comes in. I start the conversation. I explain the concerns of the wife. I've not even finished songs. The guy says, Doc, Mamela, Doc. Utabo Tayi
Utabombeki, that is.
So why should I? Now, I'm not going to get into the argument of whether he said, he didn't say. Where I was at the time was someone needed to come out and clarify.
Yes,
because the message that got to the people, if they are saying he never said that, was different, which then made our jobs harder at the time in trying to get people to do what was needed with HIV/AIDS. And then when I left in 2002, and I got here and I got my orientation talking to the physicians. Oh, you're from South Africa. So this beetroot thing. So I had to answer those questions.
Yeah.
Because of where I come from. And it was a joke, not a joke, but they just couldn't comprehend that a country like ours was having those discussions. Now, again, I'll repeat, they might have meant well, they might have known what they were trying to do, but not clarifying it became a big issue, because the information that gets to the people is, I will say, different according to them, because they'll say they never said that. But you need them to be alive to the fact that this is caused by what you started. So fix it.
No, absolutely.
And they never did.
Yeah, no, absolutely. Look, I remember there were lots of people who became quasi-scientists because the president said, and they would argue, and you'd realize you'll argue until you are like blue in the face or navy. You're never gonna win this one. And people's lives were, I know I'm also digressing now, but when I worked in the mining sector, so one of the things that I got involved with, so George W. Bush introduced the presidential something fund for Africa, PEPFAR. And so the company I worked for at the time, Extrata, reached an agreement with PEPFAR that we would match every dollar they provided. So we ended up with 2 clinics in Brayton and in I think in Delmas or somewhere there. I cannot remember now. But both of them in Mpumalanga. And the person who led the clinic was a lady called Sharon White, not the clinic, but actually the project for ONAPIA. She's very good, I must tell you. She's excellent. So to make the story short about how you work with healthcare and understand community dynamics, one of the things that she did was to get the church people and the traditional healers together, right?
Mhm.
And basically the conversation was, and I must say the mayor was very helpful. The mayor was extremely helpful because the mayor was also the digger, the municipal digger was using, basically it was a municipal digger for graves.
Mhm.
By the way, this is now 2006, 2007. And cut a long story short, they the people would go to a traditional healer, and the traditional healers were trained to understand the symptoms. So at the clinic that we built, at the back was a facility for traditional healers
Mhm.
deliberately. So a person would come to the back and say, I don't know, like I think Twaita has bewitched me and that sort of thing. And the traditional healer would say, okay, let's hear your symptoms. And, the person would say, so they would say, okay, look, I do think that also Twaita has been doing something to, but let us eliminate HIV as a possibility. I will take you out to the front. I will take you out to the front there. We do the test and everything. And if it's not HIV, then we know it's something else. Then we know it's something else. And then we deal with it that way. And that was highly successful, by the way, because you didn't like try and say, no, 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 don't talk to those
Don't go.
people.
Now,
Oh, you
now there
work
were
with,
colleagues in, I'll say Etinaga, but I
yeah,
think it's Karieja now. Some colleagues
career,
in
yeah, you know.
Karieja who are Rajeshish, Atulish. Now, what they would do, the receptionist would listen in the waiting room, what the patients are talking about. And then when the patient goes in and says they've got a pain in the rib cage or whatever, for some reason, they'd come up with a diagnosis of a pudding. That is it again. And the doctor would tell them about you stepped on it at that place and it's gone up the leg and it's stayed at your rib cage. And then they give you the medication
Yes,
that you need. And then some would come for a needle that's used to clean the blood.
yes, yes,
And those are the things that were happening. And then once the medical aid is depleted at the Tinaha surgery, then this
right,
patient will rock up in the location in the from June going forward. Doc,
right.
medical pain. Because unfortunately, in the private sector, we're going to touch on this when we come to NHI. In South Africa, the GPs are private. So
Yes,
whoever walks in the door needs to come back
yes,
and you need to contain. So you've got to give them something. If they want a needle to clean the blood, they leave with a needle to clean the blood, irrespective of whether that exists or not.
yeah,
And
yeah,
you also feed into their beliefs, which is exactly what the traditional healers are doing next door. If
yes,
libegelo, libegelo, that's it. It's
yeah,
not going to be musculoskeletal pain, it'll be ibege. And
yeah,
you'll
yeah,
be
yeah.
treated for ibege, the putin.
Yes, yes. So so let's move on from the put forth because we also try and stay within the time limits here. So the NHI gets the NHI bill gets passed by Parliament. It's when our president comes back from Ukraine in Russia, he may make some time to read the bill and consider whether it is constitutional or not and that sort of thing. But let us assume it's going to be signed into law. So here is my frustration with the whole conversation. It is made as if, at least when you hear people talk, and when people, I mean politicians, ANC politicians in particular, you hear that you get the impression that it's going to solve all our problems. Now, one of the things that always grounds my perspective on these kind of things is that I'm from a village. And so I always think about things very practically. And my village is actually, we're lucky that we about 40 k's from Tata. So you can still drive to a medical facility, and get there within a short space of time. But in my village, I've never seen an ambulance. Granted, I've spent a lot of time away, but I also do spend in December a lot of time in my village when people are back and drinking, and there's all sorts of things, stabbings and the like. and I've never seen an ambulance, first of all. And when I grew up, people would die from bleeding. Actually, they would bleed out because there's nobody to take them to hospital and that sort of thing. But I also think about places that are very far, like Mwanguba and Willow and so on, where it's a gravel road to get anywhere. And when you get to that hospital, it might have the facilities. If you're going to Tulele or Madwaleni, Tulele Hospital, by the way, had a very good medical officer there, whatever they called, and then there was internal fighting with the union. But I digress again.
Mm.
My perspective is this, and this is what I'd like us to talk about, that the NHI bill attempts to solve a part of the problem, which is people who cannot afford medical services uh, must also be able to access the kind of medical care that people with medical aid access, which is they go to St. Dominic's in East London, or they can go to Mill Park Hospital, or whatever the case might be, depending on where you are, right? But I can't help thinking that that's not the whole problem. In fact, it's a tiny part of the problem. So I know lots of people, including yourself, who are South African, who don't work in South Africa anymore. Those people are medical people right across different spectrum parts of the profession broadly. So they're not here. So in my mind, we don't have enough nurses. Lonwabo, whom we both know, is a urologist, and he was telling me how few urologists we have in the public health
Mm.
system in South Africa. And I was thinking, oh my goodness. And then he told me how few urologists we have at all in South Africa,
Yep.
right? So you get things like that. So people are in Saudi Arabia, they're in the UK, they are everywhere, right? I get the sense that we don't have enough. So I've already mentioned the ambulances. When I was growing up, the ambulance would come via a combi, and it was a mobile clinic, so it would rock up once a week. And these days it's not much better. There is a clinic in town, but people complain about it all the time, that it doesn't have all the meds and that sort of thing. You don't get the attention. You then get referred to Mtata Hospital, and you get there and you queue forever. Oh, by the way, you go in the opposite direction to Tulele Hospital if you are in Mkandul. Then they do whatever you guys do as doctors, and then you get sent back up to Mtata again, which means you drive past your home in an ambulance this time to go to Mtata Hospital. There are all of these problems, which to me says the NHI is not going to solve everything. Yet, my view is that we need to have decent medical facilities within a walking distance of your home, or a short taxi ride, or you ride for less than 15 minutes and you get to a medical facility and so on. That's what is ideal to me that we should aim for in South Africa, especially with the infrastructure challenges that we have. So I've got a couple of questions for you. Firstly, broadly, your perspective on the whole NHI thing. You don't have to quote phrases and that sort of thing. Just broadly your perspective. And then we will talk about your experience in Motherwell and elsewhere, and also in the course of your work over the years, because you help people in South Africa as well, even though you are there with advice and that sort of thing. And finally, what your experience is in the UK, and then we will open up the
Okay.
conversation. So let us start with your broad perspectives on NHI and whether I am off the mark in my impressions.
No, no, you've got it right. But what I want us to do first, just
Yes,
touching on the subject of your topic, universal healthcare.
yes,
I want
yes.
to read this so that I don't get it wrong from the WHO. I see
Mm,
Nomvula is on the platform as well. She'll correct me if
yes,
I'm. Universal health coverage means that all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. It covers
right,
the full continuum of essential health services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course.
right.
So, what that means is now from birth to death, you're covered.
Yes, yeah,
Now, we have taken the I believe, from the NHS.
yes,
The NHS is the longest universal health coverage known and it is the most common popular as well.
mm,
And if we want to use it as a template for South Africa,
Right.
it becomes a big problem. But I just want to touch on some figures because I did say before we got on that there was a Q&A in the Sunday Times with Chris Baron and Nicholas Crisp. Now, the NHS funding is from General Taxation and National Health Insurance.
Yes.
And per citizen, it is £2,647 per annum.
Yes.
And the cost for 2022-2023 was 180 billion
Right.
pounds.
Pounds. Yeah.
Pounds, yes, which translates to 10% GDP.
Right.
Now, Chris Baron asked Nicholas Crisp this question: how much is the NHI going to cost? He said 8% of the GDP, less than 8.5%, sorry.
Yeah.
And then Nicholas Crisp threw out some numbers, Chris Baron threw out some numbers. Nicholas Crisp bettered them all. And I think they settled at about 400 billion rands.
Yes.
Rands.
Yes.
So you can see now how much it costs to have the NHS and
Right.
how much it is purported to cost to have the NHI.
Right.
Now, if you then look at the population size between South Africa and the UK and the amount of people that are actually going to contribute with general taxation, chalk
Yeah.
and cheese.
Right.
Now, the GPs.
So in other words, for people who are listening, so there is a higher proportion of people paying tax in the UK
Yes.
than there is in South Africa, because South Africa has higher unemployment, and even when people are employed, they fall below the tax bracket that allows them to make a contribution to the tax base.
Yes.
Yeah.
So that will affect you from day one when you're trying to implement the
Yes.
the NHI. Now, the GPs are the core of the NHS.
Right.
Because to solve this conundrum of yours of in your village, walking distance,
Yeah.
I, even as a doctor, have to register with a GP. And my
Right.
GP is less than a kilometer from home.
Right.
Now, that GP takes the people in that area only.
Right. Right.
And I don't just need to register with the GP, I need to register with the dentist as well.
Okay.
Now, the dentist, unfortunately, they are few and far between, so you can find a dentist anyway, but it's got to be an NHS dentist. But the NHS dentists also have some private work as well, so they balance the two. But
Right.
where I'm going is, as a government, you have to register with a GP and a dentist.
Yes.
So you can walk into a GP, book an appointment, GP will see you, prescribe medication. They don't dispense. So you've got to go to the chemist, and there is a payment. For some people you don't pay, some people you pay. But if you need a referral to a specialist, that will be done by the GP.
Yes.
The news you're hearing about the NHS is collapsing.
Yeah.
Personally, I feel it's a bit of an exaggeration because it used to work very well, meaning the waiting times were less than 4 hours.
Yeah.
The appointment times for operations were less than months. But now all it means is that the appointment times for operations are longer, and the
Right.
waits in A&E are longer. Unfortunately, that's because it is that popular, it is that good. Everyone wants in. So people
Yes.
come from different countries so that they can be serviced by the NHS. But it's not collapsing to a point that a surgeon in a hospital in South Africa somewhere has to cancel an operation because they don't have the instruments to work.
Yes.
It's not that collapse. It's not that type of collapsing.
Yes. Right. So therefore, I mean so I'm glad we've touched on the concept of universal care. There's something you said in describing it, and I think it's important that we maybe just touch on a couple of things, because there's some terminology that you used. And many people will relate to this, because we usually at some point have someone in our family who needs a certain level of care. And so there is the care that you need when you're a baby, and even when the baby is healthy, they need a certain level of care, especially in the first few hours, and the first few days, and the first few weeks, and so on, to make sure that the baby is okay, right? So that's one. And then there is you mentioned things such as palliative care. And I think many of us know of instances where they say, no, the doctors have given up, they've
Mhm.
released him or her to go home, and that sort of thing, right? That is when a person is usually the most serious burden to the family. Because if that family is lucky enough, people are working, there is nobody to really look after the person, somebody has to look after the person, it is difficult. It's a bit of specialized care because a person can't do anything for themselves, etc., etc. So, what I'm understanding you to say is that universal care also has to mean that from the time that you are born all the way to the time that you are handed over to the coroner at the mortuary,
Yep.
we have to provide for you
Yes.
throughout, and also provide for the peaks in your life, which is when you're in your 20s and behaving very badly and putting yourself at risk of injury and that sort of thing through all manner of things and drunken driving, all the way through to times when you are very susceptible to certain types of diseases and so on. So what I'm reading you to say is, if we think about the normal course of a person's life, we've got to have a system that caters for all of those things that happen.
Yes.
Right.
Yes.
Okay. So I think the point I was making then about RISE is that we've decided to focus on not just the individual in that way, to focus on the family and to focus on the community.
Yeah.
Because if you take that approach, you're able to ask yourself questions such as, okay, so we're building this RDP community, whatever the case might be. What do we build first? This is what I can never understand. So what do we build first? If we're going to build RDP houses, in my mind, you already identify where a clinic is going to be.
To be yes.
People get sick. Okay, it is so logical. You think, okay, is a school nearby? How long does it take
Mhm.
to get there, etc., etc.? Okay, do we have any GPs around that can? Okay, so we need to think about what we do about GPs so that people can walk and that sort of thing. And I just don't feel that kind of planning happens. We just
No.
plonk communities, and in the villages it's worse, as you know, like
Mm.
the headman just allocates land and people build.
Listen, even with the NHI, I spoke to several of my friends, colleagues, when the white paper came out. And I asked them one question: were you consulted? And the answer was no. And
Oh,
those are the people that you need.
yeah.
Now, sorry, Godfrey has asked a question about general
General
taxation. He
taxation.
is right. It is the tax that you pay.
Yeah, it's a tax that you pay,
It's
Godfrey.
a
It's your
tax that is
income
normal
tax.
tax, but the NHS then adds another tax called national insurance on top of the general taxation. So you need the GPs. That's why I was explaining that you have to register with the GP. So the GP is a gatekeeper for everything,
Right,
and it's free
right.
compared to where you have to go and pay and get and pay a GP. Now, when you're paying a GP, going back to what you had said about the people that are working, you've got medical aid. But there's something there that confused me. I even asked it on the timeline, and some people were not sure why I was asking because I was supposed to know. Copay.
Yeah,
It doesn't. You are medical aid. Fine. It was explained to me as if it depends on the range, what you pay for. You get what you pay for, sort of thing. That if you're on the highest, then you don't have copay, or the copay is less. But what that means is that what you're paying for is not enough if you've
yeah,
got to fork out something else. And then you've got gatekeeping from the same people that are supposed to be safeguarding your health. Because here, if I'm seeing a patient, I need to order something, I order it. The only person that will stand in my way, for example, is a radiology registrar and say, why do you need the scan? The only
right,
explanation I'm giving him is a medical one, not a
right.
cost one.
Not a cost one.
Not a
Yes, yes,
cost one. So
yes,
if we
yes.
agree medically about the indication for the investigation, that gets done.
Yeah,
But down there, the medical aid will reject an investigation that is necessary, which is where, and you're still paying private for it.
yeah. In fact, sometimes they will say something is experimental when it really is. Look, I mean, there is something that I'd like us to get out of the way because And I see Biggs, how's it, Mchanam? So I see Biggs has asked a question, why are so many people in the medical space objecting to the NHI? And we'll deal with that. So I think, and part of the reason I'm acknowledging him is that there are the concerns of medical schemes, right?
Yes.
There are the concerns of medical schemes. There are the concerns of medical practitioners and so on. So Biggs, let us use an example. So my sister is a physician in the state. She has all her life, and I think she's now going on 15 years as a doctor, worked in the public service in the Eastern Cape and in KZN, right? Now, I have sometimes felt bad because the hours that people work are unreal. They're really totally unreal in the sense that somebody might be off, but they're on standby after having pulled a long shift already on a weekend or whatever the case might be, or for the last few days. So there appears to me to be just the overall issue of capacity. Then you get public sector nurses who work night shift in private hospitals,
Yes.
or if they are on day shift, on night shift in the public hospital, they work day shift in the private hospital, which means the same person is the equivalent of a pilot who's flying 36 hours. I don't know, man. That concerns me. That says at some point somebody's gonna get hurt in this equation because this person is exhausted, they're tired, they granted they need the money and that kind of thing. And I ask myself, are you solving this problem? Because what is likely to happen, and maybe we might be getting to the point that Biggs is asking. Okay, now we've got medical insurance. So we all go to Sunning Hill then.
Exactly.
Now we all
now,
go to Sunning Hill. Now
now,
we're not solving the problem still because now the waiting time is now 11 hours at Sunning Hill. Okay.
exactly. Now, Nomvula has provided some useful numbers because she
Right.
knows the system, so she's got some numbers there for you. Now, this is a big problem. But I did say earlier, if you want to copy a system, you need to have the equipment to copy because this problem you're mentioning of nurses doing moonlighting, that's the term that they use,
Yeah.
moonlighting. It's because they need to augment the salary. Though the
Yes.
salary in the
Yeah.
public sector is not as
Yes.
good as the private. Even the specialists, they also are core in the private and do sessions in the hospital. And I
Yeah.
feel that the hospitals are not accommodating these doctors adequately to make sure that they give the time to the public hospital.
Right.
Because what results in that is that they then leave the public work. Hence, your conversation with Lenoir about lack of specialists, because for their livelihood, it's better for them to be private and leave the public work if they're not going to be accommodated with the needs that they bring to the
Yeah.
table. That
Yeah.
this is what we want to be able to continue to do this. Sorry. So for us to be able to service everybody, it's a money issue.
Right.
It boils
And
down to money.
and the figures that Nomvula is providing there. So the budget allocation for National Department of Health has declined by 4.4 billion. And I think that is for the national department. That
Yes.
excludes what gets sort of remitted to provinces because
Yes.
that number is about 280, 290 billion in total. But it's grown at less than the rate of inflation
Mm.
over time, right?
Mm.
Over time,
Yeah.
and therefore, in real terms, that funding has declined. By the
Right.
way,
Yes. Now
yeah,
COVID as terrible situation that we had to endure for 3 years, but it has exposed certain nations with the lack of provision for healthcare for their citizens.
yes,
I want to use an example of COVID testing.
right,
Now, with the NHS, it was free for everybody,
yeah,
and you'd get your result the following day. Now, I was taken to task a lot of times when I was saying in South Africa, you pay. And people always raise the fact that if you go to a public hospital, you don't. But when you went to a public hospital for a COVID test, some people were telling me that on Friday afternoon until Sunday, no testing is being done in certain
Mm,
places. And
mm.
even if it's being done on a Monday, you get your results on Friday,
Yes.
which
Yeah.
is
Which is
pointless for what
pointless.
we
Yeah.
for
Yeah.
what
Yeah.
we
Yeah.
did.
You kind of want to know now.
For what we did. But if you then go to the private sector, you then get your test the following day. So the private sector was milking it. And the competitions commission, you'll know this, they had to come in
I remember. Yeah. Yeah. They had
so
to
that
intervene.
so that they can drop the prices. So people were trying to make money during the pandemic. And I'm gonna try by all means not to get into politics. I told myself for a few
Mm.
days. But digital vibes existed for NHI.
Yeah. Yes.
And we know what happened there.
Yes. Yeah.
You spoke about ambulances.
Yeah.
The Minister of Health at the time, together with the MEC for Health, were in a Kombiki River.
Yeah.
You
Yeah.
know what happened
Yeah. I was looking. I still have the picture.
there. You know what happened there. The president's spokesperson is not the president's spokesperson anymore. You know what happened there.
Yeah.
Now, I had made you touch on this that we did a lot of work for people during COVID. Even though I was here, I had many food soldiers that I'm grateful for. My
Mm.
colleagues who are just call and say, "Listen, there's this patient, go see them," and they would jump. Everything we needed done. My colleagues on the ground did it. But
Mm.
see me, my other food soldier, got very angry when I said there's no money. They said no, the money is there. It just needs to be used the right way.
Yeah.
For example, now 20 million gone in Warsaw, people sleeping in hotels
Yeah.
because the money is there, but it's not being used the right way. And when the reason people are skeptical, to touch on the question that was asked about why are people skeptical about NHI, the reason people are skeptical is because this money is being handled by people who steal money.
And if
And
they
they
don't
steal
steal it,
money.
they are careless with it. They
Exactly.
spend it on things which are not critical.
Exactly. And during a pandemic, they showed us exactly who they were. While people were dying, they were pilfering the system.
Yeah.
That is the amount that is going to these people. That is why this thing is worrying.
And what will happen with, because it seems to me to be a very simple fact also of economics, and we'll talk about the economics just now at the most basic level. The only thing that is going to be done by the state is the procurement.
Mm.
The service provision will still be private, right? It
Mm-hmm.
will still be private. What do I mean by that? I mean by that, if there is no clinic in Ngumane in Mkanduli, there is no
Mm-hmm.
clinic in Ngumane in Mkanduli.
Mm-hmm.
If the government doesn't have enough ambulances to ferry everyone with a headache to the nearest GP, they will hire somebody to do it.
Mm-hmm.
And depending on how much kickbacks are getting paid, those ambulances will get paid at rates which allow people to get kickbacks. This is the experience we know. Now, this is not to say that this level of care therefore must not be made available to South Africans. I am all for it. So I think that's my one challenge that I've got, that in the absence of the core facilities unit, you'll get a lot of entrepreneurs who says, I'm going to take the risk. I'm going to buy the Ivecos or the Mercedeses to service the rural areas because the government is going to hire me to do it. And there's going to be a tender that gets issued, and therefore we are going to start doing it. And of course, you hit the same problem, which is money runs out, and because that's the experience that we have. But let me talk about economics, demand and supply. Now, I believe one of the reasons we get these kind of problems out of medical aid that we were talking about earlier is the fact that we don't have a viable public option. Because if it was possible for 90% of my needs to go to a public health facility and get help as fast as I do when I go to a health works or whatever, you simply tell those people, no, screw you. I'm not going. No, honestly, and your medical aid package, because this is important, the individual economics of financial issues are really important because many people who are watching here do not have enough to allow them to retire. And finance ministers talk about savings and so on, but people can't save because there is a parallel state. What is that parallel state? It is medical insurance, it is private hospitals, it is private medical practitioners, private security, private schools, and so on. All of these are taking money on top of the money that you've already contributed in terms of general tax. Now, I would be happy to pay, for instance, an extra 5,000 Rand, let's say, tax. I mean, you already pay those things for various things that the state is
to
not
get that
providing
package
anyway.
included.
If it was then going to be possible for me to access state services, I actually would rather access state services because it means I can then save the money and people can retire at 60 years old, right? And be able to look after themselves. These trust fund things that people complain about and say white people have got trust funds
That's
and
one
black.
babies.
I must tell you, as long as you need a medical aid, you are never going to have a trust fund. You are never going to have a trust fund because you need medical aid, you need an alarm, you need sort of fast response security and these kind of things, right? So I think what I think is really important to recognize is that as much as the insurance part of it is important, we need to understand the pitfalls that are going to happen because of of how these things are going to work, but also that we're solving a slice of the problem. Now there is a question from Uliboheng Mabuya. Uliboheng,
Thank you. I've seen it. I was going
please
to
let's
touch on
deal
it.
with it.
Thank you. That is a great one because I'll use it together with that example of palliative care that we are mentioning. So the all those disciplines she's mentioning there are handled. They are within the NHS. So we work as a team. So in
Yes.
my ward, I've got that team. So we have a meeting every morning. We've got a physio, we've got a physiotech, we've got an OT.
Yes.
Now, when there's an acute hospital and there's a community hospital.
Right.
So when you are admitted, you get looked after from admission to discharge and at home.
Right.
So, sorry. I think let me do it this way. What does the NHS do with allied services such as occupational speech and physiotherapy? Is it accessible? So that is the full question. So all of that is available for you when you're admitted. Let's take an 85-year-old who's fractured the neck of the femur, the bone, the big bone at the top.
Right.
So you go in, you have your surgery, you come out, you get physiotherapy in hospital. The OT comes in and checks what equipment you need. They look at your home environment. They even go to your home environment to do an environmental risk assessment if it's warranted. They check that and they will say you need a Zimmer frame, you need a raised toilet seat, you need a commode. That gets provided for you. And then on discharge, you get something called a package of care. It's provided by a company called Home First. That's also an NHS package to make sure that you're discharged safe and you stay safe at home. So what that entails is you'll get 4 care calls: morning, midday, tea, we call it tea here, and bedtime. So 4 times a day, someone comes to you and gives you attention for 30 minutes or an hour, depending what your needs are. So from admission to discharge and at home. And that's all part of the NHS. You only start to pay for that when it reaches a point where they say you need a maintenance package. And then social services comes in and you are means tested. If you've got an X amount in savings, then you pay. If you don't, you are a reward of the state and they pay it for you.
Right. So there is a needs assessment. So if you can afford, right, there's a means test. Yeah.
Yes. Yeah. And then on the palliative care one, so you spoke about families looking after the person at home. So if you can take the patient home, you are still given a free package. That one is free until you die, because it's given. It's called fast track discharge. So it's given to people that have got weeks, days, or months, and
Right.
it's fully funded by the NHS. So you can get that either at home or in a facility. That facility being a nursing home. So you've
So
got
that's
different
why
types.
that's what should have happened to Shapir Sheikh.
listen, listen. I still want to see the psychiatrist that signed that thing. But anyway, that's a story for another day. So you've got residential and 24-hour care. Now, 24-hour care is more like what Danny did with life accident, but that was for psychiatrists, for psychiatric patients.
Right.
But which means the facilities are there, but when either we're not using them or the money to use them goes different places. So the care homes are part of the NHS. So it goes back to what I was saying, that from birth to death. So when it comes to you now going to a nursing home, again, it means testing comes in.
Yes.
If you've got property or whatever, then that gets put into the equation. If you don't, you don't. There's nothing that can happen. So that they can do, and then you are paid for by the state.
Now, let me ask, so what happens in cases, because we've now become aware of other conditions, right, such as autism and so on. What happens with kids with such special needs, depending on, how severe the issue is? Are they also covered?
Yes, they're also covered, but that one, now health, okay, I think we need to go back, because we started with the ambulances ferrying people to hospital. But let's
Right.
step it back a little, and then you touch on transport. Let's step it back a little bit, because for health as a whole, you need to be holistic in your approach. You've got
Right.
to be at electricity, running
Right.
water,
Right.
transport,
Yes, absolutely. Yeah.
school,
Yes.
nutrition. So all of that. So the autism part of it is more on the school side. So there are special schools.
Right. You're right.
But,
Yeah.
but now the diagnosis needs to be made first, and that's where it takes a while, because sometimes kids can be looked at, for example, ADHD, that don't behave, which is not the case.
Yeah.
So you need to make the diagnosis first, and then you get the right referral, put them in the right class, and put them in the right school. Because if that child is not in the right class, they'll always be trailing back. So you
But
need
I
to put
suppose the diagnosis is done in the health sector, though.
in the health sector, but it gets picked up from there, from home and school, and then gets
Right.
done in the health sector, and then you
Yeah.
follow them up going forward.
So by the way, so there is a term that Mandla Isaacs at Rise Mzansi, the head of policy, has come up with, at least he's introduced us to, which is system leadership.
Mm-hmm.
And his point is there is no single department that operates in isolation. There is no single issue that is dealt with in isolation either. Okay,
Mm-hmm.
so the Department of Health can provide all the ambulances it likes. If there is no road, they still can't get there,
Yes.
which means you still need to provide the roads for the
Yeah.
ambulances to go
Which is
on,
why
right?
the Kirki River, Kombi rivers, that's what we were told they were supposed to do. Go to the inaccessible areas. That's
You
what we
know,
were
as
told.
as somebody who comes from a village, I was thinking there is no, I mean, this thing, there is no way this thing can fetch anyone, especially at night. I mean, this thing doesn't even have lights.
And there were journalists telling us that,
Since you like, no, but
defending that thing.
so I know I'm digressing, by the way, but it's a related issue. One of the things that occasionally would annoy me when I was in the newsroom, and I'm mindful of time, when I was in the newsroom, was how this transformation debate was understood. Media transformation. Do you have enough black people? Do you have enough women? And in my view, I always thought you also need people with diverse experiences. By the way, and I find some of the stories that would get written. I mean, the Eastern Cape is a disaster, obviously, at a government level, and the rest of the things. But I would read stories where X number of kids have died of diarrhea in hospital X and that sort of thing. And I think, but I know what happens in our villages though. A child has diarrhea, like it starts at 9 today, a.m.
Mhm.
Okay. At 5 p.m. that day, they're still saying, yeah, if this child doesn't improve by tomorrow, then we'll take them to the doctor. Now, the doctor is far. I mean, it's so far. I remember when I was growing up, I only saw a drip, by the way, when I was about 15. I had never seen a drip before. Honestly, I had never seen somebody in a drip because there was no facility where a drip put on somebody. But the point I'm making with this with this story is that you need a range of other infrastructure
Yes.
to make a certain part of the whole system to work. And so you need the roads, you need clean water. And so the irritation for me was it's now written as if it's a problem that is caused by the hospital. And I think, well, maybe the hospital could respond better, but chances are
Yeah.
that 5 year
Started
old child, by the time they got there, they
exactly. Now,
were gone.
you've reminded me of something because I wanted us to discuss this, but thank you for bringing it up. So, my mother was a teacher when she was still working. So, I
Right.
remember in primary school, she was very obsessed about washing food.
Yes.
Hlamba le basic uzaba ne-cholera. Now,
Yeah, yeah.
that was in the 80s.
Yes, I remember the cholera thing. Yeah.
In the 80s.
Yes.
2023, I think we're sitting at 40 something odd deaths from cholera.
Yeah. From cholera. Yeah.
2023. Do you know what the politicians are doing? I'm sorry, you're a politician as well. But they're busy
Yeah,
pointing
yeah, no, please go ahead. I'm still in denial, so it's fine.
they're busy pointing fingers at each other. And yet in 2023, all I'm seeing is in 2023, South Africa has had 45 deaths from cholera. That shouldn't be happening
Yeah, at all. Yeah, yeah, at
at all.
all. At all.
Be
Yeah,
it
should be
you are
happening.
the president, you are running this program, whatever. It should not be happening. And it goes back to the water that you've mentioned. Now, the contract to deal with that water was given to so and so who is linked to so and it goes on. But nothing has happened. All the president did was blame another organization, another political party. That's it.
Yeah.
But in 2023, that should not be happening.
So I mean, so one of the things we I don't want to say we're battling with, we're trying to figure out is how to talk about things holistically. So, for instance, some people who read our documents at Rise in Mzansi may find that we don't have the usual themes that you have in the manner that we understand them, where you've got health, education, etc., etc., etc. And that's because part of what we're trying to do is to find an expression that brings them together,
Mm.
because when you talk to people in communities, whether it is whether it is in focus groups or it is in community meetings and so on, there is certain language that people use. So for instance, they will not use crime, they will use safety. They will say we want to feel safe. And when you dig into what do they mean by they want to feel safe, you find multiple disciplines in
Mm.
the answer they give you. There is crime, there is all other things which fall in different departments, right? Um, and there's something I'd like us to talk about, something which Nomvula has raised, which is the role of district health management offices,
Mm.
contracting, etc., etc., right? And so, and that is when you are running a system as complex as what the NHI is going to end up being, right? A You also need people with a certain level of skill and knowledge who understand how things should cost. So let me give an example which is totally unrelated. So when I was at APSA, I ended up being a head of both communication and marketing. And once I got involved in the marketing, I realized there are agencies, and we employed one whose job it was to look at quotations, especially from ad agencies and so on. that are providing, that are going to be shooting an ad. Okay. So this is amazing. So these guys basically look at the quotation and say, no, 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 but why are you using this camera, which costs X
Yes.
thousand per hour? You can use this one. It does exactly the same thing.
Mhm.
And so they go through a quotation, right? They go through a quotation, and eventually something which was going to cost you 3.5 million or 3.8 million ends up costing you 2.7 million. And you save over R1 million as a result of it. And
Yeah.
that's because there was a recognition over time that the marketing specialists who work within the department don't have that level of specialization to
Yes.
know whether a
Costing
quotation
it.
is inflated or
Or
not.
not.
Because
Yes.
of course what happens is they say they're going to use camera A, they still use camera B, which is cheaper. And they take the money and they run. And so I do think that part of what Nomvula is saying is that you also need, at as low a level as possible, local a level as possible, people are going to be doing this contracting, A, being immune from corruption, and secondly, those people also going to know what they're doing and what they're looking at when they look at a quotation and can be firm enough and are sufficiently empowered to make the right decisions. Here's a
Now,
problem. Yeah,
immunity from corruption. I think we need to build a medical school to be able to deal with that. A
right.
new one.
Immunity. Oh yeah, yeah. No, no. Yeah, yeah. No, that's true. No, no, I missed the joke. I missed the joke. But by the way, so one of the things I believe, so okay, this was confidential, so I can't mention the consultants, but there is this conversation about the public sector wage bill, and I know we are a little bit all over the place, but since we're talking about providing high quality healthcare to people, this is important. So let me just say, I have a philosophy that if you want the best people to work in government, you've got to pay them well.
Pay them. Pay them.
You've got to pay them well. There appears to be a belief that you can pay a DG, a middle manager's salary, and then they will also not be immune. They will also be immune to being induced and
Used, yeah.
corruption and this sort of thing. Okay, like I don't know how this works, but I also see some of the newspaper coverage. When I was at Business Day, we never used to do those stories to say that DGs are getting paid too much. I always found it nonsensical. Someone has a budget of 85 billion. They are getting paid the salary of a middle manager in the private sector. And you are here writing an article saying they get paid too much. Come on. I mean, get real here. They're getting paid 0.00% of the budget they control. So here's where I'm getting it. Am I wrong or right in saying that we need to invest in three things primarily? One, this, making sure that there is a strong pipeline of medical personnel in South Africa, which takes you into the education space and who's able to do what qualifications and so on. And it's a system leadership again. So that's the first thing that you do. The second thing, and these are not necessarily in sequence, you make sure you invest both in existing and new facilities to provide localized healthcare, especially in areas where people have to incur a cost to access medical care. In other words, you no longer have to pay 600 rand to take somebody to hospital. It's 30 rand, right? If for now you still can't
Yeah.
access a GP. So that's the second thing. Make sure there's a clinic with the right medical personnel because you've produced a pipeline. So that is the second thing for me. The third thing, the third and last thing, is to be very clear about how you're going to use both the public and private infrastructure to provide
Together.
highly specialized care that people need. Am I mad?
You're not mad because that's what's needed. Will it happen? That is the question. Now, this, I'm not sure Lonwabo would be able to phrase it. There's a term that they use with this private public partnership
Right.
where they're supposed to do sessions in the public and
Yeah.
work in private. That relationship is not there. The specialists are living in droves. So if they can't do it before NHI, how are they going to incorporate it into NHI? Because as you've said, you need to make the people that are going to be doing the work happy, and you only make them happy with remuneration. The reason they go private is because of the remuneration is not adequate enough.
Yeah. Now tell me, so a person who works in a medical facility, is there a global standard for where the amount of hours you can work in 24 in a day?
Yes, there is. It was the. Oh, I ignore that thing because we always want to work, especially when you're on an hourly rate. But there is a. When we were still part of the, I'm saying we because I'm talking about the UK now, part of the
Right,
EU. There was
right,
an EU standard of how many hours doctors can work a week,
right.
but the agencies also found a way of getting around that.
Right. No, no, I get you. So the reason I'm asking this is that I there is something we haven't touched on, and that is the kind of treatment people get in medical facilities, especially public health facilities, right? Where the behavior of the nurses and other medical personnel is uncaring in many ways. Now, I also think sometimes that, okay, let me think about working conditions. I don't have enough tools of the trade. One, in that the facility in which I work doesn't have everything that it needs in order for me to provide the care. That's the first thing.
Yeah.
The second thing is because there are few of these facilities, the number of patients I get is
Yeah.
beyond what I can handle. So that's the second. And yet I need to process all of these patients in
In
a
this time.
reasonable time,
Yeah.
right? Which means instead of spending 7 minutes, let's say, let me throw a number, on trying to understand what a patient is feeling and so on, I'm going to spend 3 minutes. And in that 3 minutes, I don't have time to be nice. Okay. Like, move. There's like 200 people behind you, and I still need to go for lunch because I'm hungry.
Mm.
Right. And on my way to work yesterday, the taxi got stuck, and so I only got home at 11. I'm tired. I am all of these things. Now, I am not excusing the behavior of nurses. I was asking you that question because I also have a feeling that there are other related issues that affect the quality of the healthcare that people get.
Yeah. I think that one is a big problem because if someone needs to go to a hospital, let's say tomorrow,
Mm.
there are people who know that they need to be at the gate at 3 a.m.
Yeah.
to be able to get seen at 9 or at 8 when that facility opens.
Yeah. Yeah.
But now you don't know how bad the people in the queue are. Now,
Mm.
for them to get there at 3 a.m., going back to what we've already touched on how did they get there transport wise? Because that facility might be a fair distance from them.
Yeah. Yeah.
And then you've got the nurses that are doing the triage, that is like looking at who needs to be seen first.
Yeah.
Now, unfortunately, if you've had a bad night, you fought with a significant other, your salary is not enough, there are many things that are working on you that unfortunately will affect how you deal with other people who were not part of the problems that are
Mm.
making you deal with them that way.
Yeah.
And
Yeah.
then that treatment unfortunately then gets meted out to the people that are waiting. It does happen, and any doctor will tell you of the stories that they experienced in the labor ward when they were when they were training. The nurses in the labor ward are very notorious for that.
Mm.
The language they use when girls, I'll say girls because it's usually 16, 17, 18, and they were having all the complications in pregnancy. But the language that they use, well, they're crying, it's painful, and then they'll be slapped in the thighs, and then the language used about opening the legs and all of those things. It's vile, but it
Mm.
does happen.
Yeah.
And it's not supposed to, but it does.
That does touch, by the way, on other social issues because I was in a conversation and I'm mindful that we're now 6 minutes over, so we're gonna close just now. And that is, you know, I met a really good public servant in the Eastern Cape. I just forget her surname now. She's a doctor,
Mm.
but she's in the department rather than in a facility, and she was explaining to the community meeting the problems of kids who get pregnant, that there is now a trend, at least in the that they're seeing in the Eastern Cape Department of Health, where the kids from rural areas are getting pregnant, the kids from peri-urban and urban areas are getting HIV, and the two are related. So the kids get pregnant in the rural areas because to talk of contraception
Yes.
is out of the question.
Yes.
The torrent of shouting and moral admonishment is just untold, so they don't go, right? The ones in the urban areas, they get access to contraception because they can go to a clinic. The problem is they then feel that
The safe.
they can
Yeah.
have less safe sex. They don't have to use protection, right?
Yes.
And so these two things are leading to these patterns. But then she went further and she spoke about how those kids within a few years they suffer from all sorts of subsequent conditions, cervical cancer and so
Yeah.
on. And I remember thinking, sure. So I'm reminded of this in that point you were saying that you it's cradle to grave basically that you need to
Mm.
provide for and provide for all of these dynamics. And some of the solutions to the public health problem are not out by medical professionals. So one of the things she said was she teaches mothers to say, go with your child to the clinic so that the people who would gossip rather gossip about
Front
you
of you.
instead of the child.
Mm.
And these are real social issues that we deal with. And I think maybe a discussion just around the NHI and the technicalities of it kind of makes it difficult sometimes. I mean, of course, we are not prevented from having the conversation,
Exactly.
of having a holistic conversation.
Now, I
So
hope you are looking at what Nomvula has put in there about Nehao.
yeah, no, no, that was going to be my last parting shot. And by the way, I will make an example, a real example of Vul. So one of my colleagues in the Eastern Cape, to protect the innocent, I will not be very specific about the ANC. But so during the recent strike, so some of the people in that union in Nehau get admonished by the ANC for the behavior, like pulling people out of ambulances, but not, I believe, in the right way. So basically, they're admonished on the basis that they belong in the ANC, therefore they shouldn't strike against the ANC, which is also not a helpful argument. But some of them are very unhappy now. So they talk to our people down in that town. I nearly mentioned it, and they say no, no, no. They want to join Rise, especially if we support them in the strike. So I then said to our people there, okay, there's one condition. That condition is we are not pulling people out of ambulances and denying critical care to people who need it. If we can have that conversation and agree on that, then we can talk and take the conversation further. Of course, I've never heard back from those people again.
Now, as you know, we've had strikes here. Now, the strikes, the unions ballot the members, and the members vote whether to strike or not. And the date of the strike is set. For example, now the teachers will be striking on the 5th and the 7th of June,
Right.
and the doctors will strike. So I can go to work and I'm unhindered. All they'll do is stand outside the gate and we hoot to give them support. And we
Right.
go and work. But no one is being pulled out of theater. Theaters are not locked so that people
Yeah.
don't get operated on.
They don't get operated on. Yeah, yeah, yeah. No, no. In fact, I witnessed something in Germany. I think it was 2001. I was stunned. So Germany is highly unionized, and so they two things. One is a picket. If a
Yes.
picket is supposed to be between 1 and 2, I must tell you, at 12:59,
Done.
people put everything down,
Back
out,
to work.
they gone, right? They pick at 2 o'clock, they walk back in and they start working again. So that was the one thing. The second thing is when there is a strike. So if you're an essential worker and there are people who are deemed to be in non-critical positions who are
Mm.
working, and the phone of the non-critical person rings, they don't pick it up.
No, we're focusing on this
Right?
side.
So there are ways around this thing. I think for me, which when you understand what critical and essential are, you can still apply labor rights in a way that doesn't violate the rights of other people.
Mm.
And of course, Nomvula, what we have here now is we've got the schools being hostage to unions, the public health facilities being hostage to unions, law enforcement being hostage to unions, the prison system being hostage to unions, and so on.
Mm.
And I feel, which is a discussion for another day. And I don't want to use Margaret Thatcher's term, which is to break the unions. We don't need to break the unions, but we need to change the culture of trade unionism in South Africa so that they apply their democratic rights
Mm.
differently. Anyway, parting shot, Doc. What would you tell us? You've got this bill. There's going to be a lot of conversation about what it is and what it's not, and so on. And it's going to be dominated by medical aids and this kind of people. If I'm ordinary Joe Soap in Kohan in KSD, what should I just keep in mind? What should I focus myself? What's important? Not
Okay.
just about the NHI, but my health.
Okay. About your health. Let
Yeah,
me read. Let me read this. Protecting people from the financial consequences of paying for health services out of their own pockets reduces the risk that people will be pushed into poverty because unexpected illnesses requires them to use up their savings, sell assets to borrow, destroying their futures and often those of their children.
mm,
Now, in the Bill of Rights, provision of health care is there.
yeah,
This is what the government is supposed to be doing to protect the people. As you remember, during COVID, medical aid scheme CEOs were sitting in the head table with the president.
of course.
Yes. So those people are important to the president and their balance sheet. The NHI is coming into play. How are they going to influence how it works? The GPs are working privately. They're earning an income for themselves and their families. How will they be impacted by the NHI? I'm
Yeah,
saying this one particular for the GPs because, as I explained, in the NHS, the GP is the NHS.
right.
So the population that they cover, wherever whoever lives in that catchment area belongs to them. So they
Yeah,
don't need to be running after patients and making sure that the surgery is
I
full.
see. Yeah,
They get paid.
yeah,
And then in that case, you don't have that situation I was joking about earlier on about inaltio clinicas, because you don't
yeah,
have to be having foot traffic all the time. And by
yeah,
the way, we never had a COVID script here, but back home, you had to leave with something if you go to the doctor. You can't leave without anything because that patient is not going to come back because you
yeah,
didn't treat them. And unfortunately, we're dealing with something where you don't know what the effect is going to be, and most of the time it was self-limiting. But you need to give something because you get paid and you need to service your own debt. So
yeah,
how will the NHI incorporate the GPs? How are
yeah,
the medical aids going to deal with it?
yeah,
Will they
yeah,
be able to work with it in a way that is conducive for the beneficial, to the patient? Because all of this should be to the benefit of the patient so that they are not in financial dire straits.
yeah. And by the way, I mean we often think, I mean, medical aids are not angels. I've seen court cases where people are forced to go to court to force a medical aid to meet its obligations, and you think,
Yes.
but this is just This is just not on. This person is sick.
Yes.
Okay, you signed up, you chose to take the risk. Yeah, it is. You pay for it.
But, yeah,
You were happy to take the premiums when the person was healthy. Now the
exactly.
person is sick, you don't want to pay.
And
And by
yeah,
the
there's
way,
that one that had to go to court for the situation in Mauritius, and the guy won.
no, I remember that. In fact, in closing, I mean, from my part, I think the way that I would ask people to always think about any policy issue is how much it works affects other parts of your life, not just this part of your life. Other parts of your life. Seriously. Helen Zille might have used a derogatory term and called people refugees. The reality is that we do transport our parents from the Eastern Cape to whichever province we're in because you just think they're going to get better care there. It
Mm.
happens, okay? And we shouldn't be having to do that.
Yes.
It should be possible for our parents and brothers and sisters to go to a local facility and get the kind of medical care that they should get. And I
Yes.
think that's important. The second thing I would like to ask people on this stream is that think about how what you have to spend in order to access the one thing.
Yes.
Because there is like the whole lot. I mean, I used to go and queue for medication for my grandfather at Mtata General Hospital, and we used to leave Mganduli at like 4:30.
There you go.
And we would get the medication at 2:30.
Purpose 4 in the afternoon.
Yeah, we got there like at 5:45, and we've been there ever since. And you're just queuing the tedium. So there is dignity as
Mm.
well.
And that
And
affects compliance with the medication because if you've not made that trip 5 days before you run out, and you've made it on the day that you run out and you get there, it's not available.
it's not
It's got to
available.
come the following week.
Yeah, no, absolutely. Doc, thank you very much.
Pleasure.
I hope that with this conversation, we've kind of had a more holistic conversation
Mm.
about what good healthcare provision is, especially by the public sector and not just through medical aids.
Thank
And
you.
one of my dreams is that we have people don't only have medical aid for super chronic rare. Honestly,
No.
I that's what medical aid should be for. It shouldn't be for headaches, man. Come on. Honestly, got a headache. Will that be on the medical aid? You're like, but why? Anyway, thanks, Doc. Have a
Thank
good
you.
evening.
Pleasure.
Sorry we went through.
Thank you.
All right. Cheers.